All right. So good evening, everyone. So I am myself Dr. Rajesh Gubba, and I'm the general medicine educator on this Unacademy platform. So I have come up with a new series of question paper, like question patterns that can appear for your INI CET exam and as well as the upcoming FMG exam. So what I have tried to incorporate is I have tried to incorporate the clinical based questions with images. So that is a bit little new thing like what I have come up with, and all the questions are very interesting questions. You will definitely like all those questions. So I wish that you should definitely watch this particular session. So the questions are so interesting that you might not have heard these particular questions previously anytime, right? So that I can assure you. So this particular new pattern of questions related to your INI CET exam and as well as FMG exam, I will be discussing every day at 10:30, right? So every day 10:30 p.m. I'll be discussing these particular questions. So before that, let me just give you a small update related to the Unacademy subscriptions and all. So let me tell you regarding the Plus subscriptions. So once you subscribe to the Plus, you can attend all the daily live classes, of all the batch courses. And we have made all the courses in a very structured format. And you also have live tests and as well as quizzes, and you have unlimited access. You can access to any course once you have subscribed once to the Plus subscription. And for that, you can use my code Dr.Raj10, wherein you can get 10% discount as well. And Unacademy has come up with what is called iconic subscription. So those students who are missing that recorded sessions, right? So along with the live sessions, you can also have the recorded sessions through the Prep Ladder platform. That is what is your iconic subscription, right? So this is one of the best subscription what you can get the advantage from. And the other important thing is we at Unacademy every day at 8 p.m. we are conducting the free live tests on Unacademy NEET PG app. So please download the app, right? How you should download the app? Go to the Play Store or go to the App Store, type Unacademy Learning app, wherein the app gets open, right? You need to click on the open. Then in the courses, you need to select the NEET PG category. So once you select the NEET PG category, you will get access for all the special classes and as well as the plus classes, right? And you have the different modalities of the subscriptions. So you can do 6-month subscription, 12-month subscription is there, and as well as 18-month subscription is there. And whatever the subscription you take, you can use my code Dr. Raj10, wherein you can get 10% discount on your subscriptions. Okay, right. So with this basic introduction of how to use the Unacademy platform, now let me come up with this very important questions and beautiful questions, and these are the questions that are expected in your INI CET and as well as FMG exam, right? So let us come up with the first question. A homeless person, he had a toothache for several months before the development of foul-smelling cough and dyspnea. This disorder most commonly associated with septic thrombosis of which one of the following vessel? I have given you the image also, and I have given you the options as well. The internal jugular vein, external jugular vein, internal carotid artery, cavernous sinus thrombosis, subclavian vein. So this disorder is most commonly associated with septic thrombosis of which one of the following vessel? Yes, so may I know who will be the first person to answer this question? Yes, Shifali Gautam, Anasuya Biswas, hello, good evening. Right, so we are getting the answers, out of which okay, so Prati has answered. Very good, Prati. Excellent. Yes, Prati, the answer is internal jugular vein. Yes, Prati, can you tell me what is this disease and what is this syndrome? Right? So not only Prati, anyone can make an attempt, but the answer is the internal jugular vein. Any one of you, please? What is this syndrome? Very good, Vivek Kumar. I didn't expect that, right? But you should be little clear with your spelling. That particular syndrome, it is nothing but Lemierre syndrome, right? That is nothing but Lemierre syndrome. Okay, so this particular patient is suffering with what is called as the Lemierre syndrome, right? Now, what is this Lemierre syndrome? Can anyone tell me what is the organism which is responsible for this Lemierre syndrome? Yes, Kaushik Chakraborty, right? Very good, excellent. But can you tell me the organism which is responsible for this septic thrombosis in Lemierre syndrome? Yes, who will be the first person to tell me what is the organism in the septic thrombosis in Lemierre syndrome? Oh no, not Clostridia, Vivek. Right. So the organism is Fusobacterium necrophorum. Right. So this is an absolutely new point. Right. Absolutely new point for you. Right. The organism is Fusobacterium necrophorum. So this is a gram-negative rod. Right. It's a gram-negative bacilli. That is the one which is associated with the development of your Lemierre syndrome. Right. Now, what is the source? Now, why is this particular internal jugular vein having the thrombosis here? Where is the source of infection? Let me tell you, in case of Lemierre syndrome, the source of infection is from the oropharyngeal area. Right? It could be from pharyngitis, tonsillitis, or peritonsillar abscess, dental abscess. So from these areas, right, from these areas, the organism can spread into the internal jugular vein, right? After the organism spreading into the internal jugular vein, it will cause thrombophlebitis, right? It will cause thrombophlebitis, and secondary to this particular thrombophlebitis, there will be stasis of the blood and there can be thrombus formation. And this thrombus, it also contains the organism. Now, because this thrombus contains the organism, right? Because the thrombus contains the organism, this is considered as the septic thrombosis. Right? This is considered as the septic thrombosis. Now, can anyone tell me what is the treatment for this particular Lemierre syndrome? How do you want to treat this Lemierre syndrome? Any one of you? Yes? So remember, this particular Lemierre syndrome, see, what am I very much worried about? What am I very much worried about is this particular septic thrombus, right? It can undergo embolization. Right? It can undergo embolization. So once this particular septic thrombosis undergoes embolization, that is what I am very much worried about. Right? That is what I am very much worried about. That is embolization. So now what I will do? Definitely for sepsis, I will give antibiotic. Right? Definitely for the treatment of the sepsis, I will give the antibiotic, right? So either clindamycin, penicillin, chloramphenicol, and even metronidazole. But it's okay. That will nullify the organism, right? These antibiotics, they will be acting as the antibacterial regimen. But what should I do for the stoppage of the prevention of the embolism? Right, stoppage of the prevention of the embolism. So there, what I will do is embolectomy. This is a very important stage of treatment. Along with antibiotic, let me tell you, you should also do embolectomy. If you don't do embolectomy, there is a chance that this particular embolus can spread to distant sites, which I am very much worried about. So that is the reason why the mainstay of treatment, it will be embolectomy. Right? Along with that, you need to give the antibiotics as well. Okay. Now let me tell you, in the today's session, all the questions will be related to your cardiovascular pathology. That means questions related to your cardiology and questions related to your pathology. Right? It's not just only cardiology, even vascular pathology. Okay. Right. So the first question was related to your vascular pathology. Now you see the second question. So yes, so did I tell you some new point today? Fusobacterium necrophorum causing Lemierre syndrome. Right, now let me move on to the next question. Yes, this is quite another interesting question. Right, good, thank you very much. So you see the next question. 5 days previously, Ramipril was prescribed for a 60-year-old man with type 2 diabetes mellitus. He now presents with condition shown here. What is the diagnosis? Nephrotic syndrome, hypothyroidism, Ramipril allergy, angioedema associated with ACE inhibitors, superior vena cava syndrome. So what do you think is the answer? Right. So this is like little easy question. That is angioedema associated with the ACE inhibitors. Now please tell me why there will be angioedema with ACE inhibitors. Why there will be angioedema with ACE inhibitors? Any one of you? And why do you want to give ACE inhibitors? Right, very good, Nurul Khan. So the angioedema is mainly because of increase in the bradykinin levels. Right, apart from bradykinin, any other substance? Apart from bradykinin, is any other substance increased because of the intake of these ACE inhibitors? Yes. So apart from, so what these ACE inhibitors will do is, ACE inhibitor, very good. So these ACE inhibitors will prevent the degradation of bradykinin and as well as substance B, both of them. Right? So actually your angiotensin converting enzyme, they are the one which will degrade the bradykinin and as well as substance P. Right? But once you give ACE inhibitors, they will prevent the degradation of the ACE. Once you give ACE inhibitors, they will prevent the degradation of bradykinin and as well as substance P, and thereby that will make the individual to land up in angioedema. And this increased bradykinin and as well as increased substance P, they are also responsible for the development of dry cough. Right, they are also responsible for the development of dry cough. Okay, right. Now why should I give the ACE inhibitors in type 2 diabetes mellitus? Yes, why should I give ACE inhibitors in type 2 diabetes mellitus? In what way? Yes, Abbas, you have said they are renoprotective. Can you tell me in what way they are renoprotective? Can you tell me in what way they are Very good, Nurul Khan, excellent. So these ACE inhibitors, they will reduce the intraglomerular pressure. By reducing the intraglomerular pressure, they will reduce the proteinuria. Right? They will reduce the proteinuria. So in order to prevent the development of diabetic nephropathy, I will give ACE inhibitors if he is hypertensive in a diabetic patient. Right, in a diabetic patient. All right. Now we will move on to the next important clinical question. Right, and another important point what you should know is the angioedema which is seen with this ACE inhibitors. Now how many days back he has started the treatment? 5 days previously he has started the treatment. Right, 5 days previously he has started the treatment. So now you see this point. Angioedema usually occurs within first week of the therapy. Within first week of the therapy. Now, can anyone tell me, right now, can anyone tell me, how do you treat this patient now? right? How do you treat this patient? Yes, who will be the first person to tell me how do you treat this patient? Not the question of giving ARBs. Now, how do you treat this angioedema? How do you treat this angioedema? That is what is my question. Prati, Ravi. Okay, we will replace ACE inhibitors with ARBs is the next point. But how will you treat this angioedema? That is what I am asking. So, how do you treat these patients is, So, first of all, you stop the drug, right? Then you give antihistamines, right? Antihistamines, and then you can also give steroids. Then you can also give steroids. So that is how you will treat these patients, right? You need to give antihistamines and as well as steroids, and then stop that particular ACE inhibitors. So that is what is the treatment for the angioedema secondary to your ACE inhibitors, right? Antihistamines should be given, corticosteroids have been used, and as well as the epinephrine, all right. Next. Yes, another clinical question, right? Very, very important question. And let me tell you, in the upcoming FMGE exams, in the upcoming INI CET exams, these are the type of the clinical questions which are expected. So you should be completely thorough on these clinical questions. So in order to see that, you should have that comfortness for these clinical questions. Every day 10:30 on YouTube, I will be coming in front of you to discuss these type of questions. Okay, right. So you see the next question. A 38-year-old man with stage C congestive heart failure remains symptomatic in spite of the diuretic therapy, and you are considered adding second and perhaps the third agent to his regimen. Which of the following pharmacological agents used in the management of the heart failure lacks trial data, right? Lacks trial data indicating a mortality benefit and does not prevent maladaptive ventricular remodeling. Right, so fairly good, excellent, appreciated very much. So the options are ACE inhibitors, spironolactone, beta blockers, digoxin. So the answer is digoxin. Now let me just give you an explanation here. So the patient is in stage C heart failure, right? And also symptomatic. Now if you see the drugs which will prevent the cardiac remodeling or which will prevent the ventricular remodeling, these drugs include, can anyone tell me what are all the various drugs which will prevent the cardiac remodeling? Yes, what are all the various drugs which will prevent the cardiac remodeling? Any one of you? So we have ACE inhibitors, right? We have the beta blockers, then spironolactone. So these three group of drugs, they will prevent the maladaptive ventricular remodeling, right? They will prevent the maladaptive ventricular remodeling. But remember, digoxin, right? Digoxin will not prevent the ventricular remodeling. It can be given in congestive heart failure, but it will not prevent in the ventricular remodeling of the heart failure patient. Okay, now tell me, what is the indication of digoxin in heart failure? Which type of heart failure you will give, and what is the indication of the digoxin? Any one of you? Which type of heart failure you will give this, first of all, and what is the important indication of digoxin? No. Right, Banu Prakash, you should not give in acute heart failure at all. In acute heart failure, digoxin has no role. Acute left ventricular failure, digoxin has no role, right? Okay, Nurul Khan has answered. Very good, Nurul Khan. So you have this digoxin has a role in systolic heart failure. That means heart failure with reduced ejection fraction. So in heart failure with reduced ejection fraction, we give this particular digoxin, right? Not in case of decompensated heart failure, not in case of acute heart failure, right? And you should give along with the heart failure, if there is presence of atrial fibrillation, that is an absolute indication for your digoxin, right? Absolute indication for your digoxin. Okay, so if the question is asked in which type of heart failure you will give digoxin, the answer should be heart failure with reduced ejection fraction. What is an absolute indication? If the heart failure is associated with atrial fibrillation, digoxin can be given. Now, in which clinical scenarios of heart failure digoxin is not advised? That means it is not useful. Digoxin is not useful in acute heart failure. It has no use in acute heart failure. Okay, so the answer here is heart failure with reduced ejection fraction, you need to give digoxin, right? Next. Now, the other very important question, right? So this is an excellent question and superb question. We have a 45-year-old woman was admitted with cardiogenic shock and was supported with a, so what is she admitted with? Cardiogenic shock. And for this cardiogenic shock, she was put on IABP, intra-aortic balloon pump, right? She was put on intra-aortic balloon pump, and she was also put on left ventricular assist device. And after placing the patient on intra-aortic balloon pump and as well as left ventricular assist device, she experienced considerable intravascular hemolysis. And secondary to that particular hemolysis, she required more than 180 units of packed RBC. And you are called for a dermatology consultation, right? So you are the consultant dermatologist. Then you have gone there, you have seen the patient and you have treated the patient. The lower photograph was taken after your advised treatment. What was the most likely treatment you have given? What did you give? So you have given, Shifali says corticosteroids. Prati says chelation therapy. Okay. What is the diagnosis first of all? Can anyone crack the diagnosis? Yes, what is the diagnosis? Prati, what do you think is the diagnosis? Why do you want to give chelation therapy? Very good. So we have a username by doctor. So the doctor has given the diagnosis, that is hemochromatosis. Very good, doctor. So very much appreciated. So hemochromatosis. Now, can anyone tell me? Very good, Shakti Ravi. Excellent. Very good, Prati. Superb. Can anyone tell me what is the triad in hemochromatosis? Yes, can anyone tell me what is the triad in hemochromatosis? Yes, what is a triad in hemochromatosis? Yes, who will be telling me first what is a triad in hemochromatosis? Right, so in hemochromatosis, the triad is diabetes mellitus, hyperpigmentation, right, hyperpigmentation, and then cirrhosis of liver. Not arthritis. Yes, Rajesh Sarkar, it is not arthritis, cirrhosis. So this is a triad, right? This is a triad. Right, this is a triad. Right, this is a triad in hemochromatosis, right? So can anyone tell me what type of cirrhosis you will see in hemochromatosis? What type of cirrhosis you will see in hemochromatosis? Is it macronodular or is it micronodular cirrhosis? No. Nurul Khan, hemochromatosis will cause micronodular cirrhosis. Less than 3 mm size of the nodules. It is not macronodular, it is micronodular cirrhosis. Okay, so now this particular patient had secondary hemochromatosis. This patient had secondary hemochromatosis. Now, can anyone tell me what is secondary hemochromatosis? Why did she develop secondary hemochromatosis? Right? Why did she develop secondary hemochromatosis? Any one of you? What is the underlying precipitating event? Yes. So the underlying cause for the secondary hemochromatosis is 180 units, man. 180 units of the packed red cells have been infused in the individual. So 180 units of packed RBC, that is the one which has caused the development of hemochromatosis within the individual. Okay. So it is a secondary hemochromatosis. Then can anyone tell me what is primary hemochromatosis? What is primary hemochromatosis? Anyone? Why is this due to? Primary hemochromatosis is due to. Ayyo, Prati, why Wilson is coming here? Very good, Nurel Khan. So, primary hemochromatosis is due to gene mutation, and that particular gene mutation is HFE gene mutation. Right? HFE gene mutation. Okay, so HFE gene mutation, because of the mutation of this particular gene, there is increased absorption of the iron across the GAT. Right, there will be increased absorption of the iron across the GAT, and that is what is your primary hemochromatosis. So in this patient, what you should give? You should give chelation therapy and as well as phlebotomy, depending upon the viscosity of the blood. Right, phlebotomy. Can anyone tell me what is the name of that particular chelating agent? What is the drug used for the chelating agent? So we use deferoxamine. Okay, so this is the chelating agent which is advised in this particular group of individuals, right? So now these are the questions, right? These are the questions. So these are absolutely a new pattern of questions where they will integrate the image with a clinical based. And these are the type of questions what you will be expecting in your upcoming INI CET exam, right? So I will be coming to you daily live at 10:30. Every day at 10:30, you will be asked to do the clinical based questions. So do you want one more question or shall I stop here? Do you want one more question? Right, so I'll just ask one more question. Yeah, okay, fine. Yes, yes, so this is another very good question, very good question, and this is the question definitely most of the students, they will have little confusion, and let me see how many of you can answer this, right? Yes, chalo, take the challenge. A 60-year-old woman with a history of hypertension, 1 second. Right, so with a history of hypertension and mild COPD presents with a new complaint of progressive dyspnea. Which of the following would best support a definite diagnosis of left-sided heart failure as the cause of this patient's new symptoms? Grade 4 to grade 6 murmur at the apex that radiate to the axilla, fixed splitting of the S2, recumbent dyspnea, pulses alternance, S4 gallop. Chalo, take the challenge and let me know the answer. Oh, very good, excellent. Very much appreciated, Durga Ratnam. The answer is the pulses alternance. Right, already we got the answer. Right, already we got the answer. So Durga Ratnam has answered it first. Very good, Durga Ratnam. So the answer is the pulses alternance. The answer is pulses alternance. Okay, now I just cracked this entire question now. Right, let me crack the question. So what is the question asked about? What is the question asked about is which of the following would best support, right, would best support a definitive diagnosis of left-sided systolic heart failure as the cause of patient's new symptoms? That is a question. Now grade 4 to 6 murmur at the apex that radiate to the axilla. Can you tell me where do you get this? In which clinical condition you will have this grade 4 to 6 murmur at the apex that radiate to the axilla? Yes, anyone? That is in MR, mitral regurgitation. That is in case of mitral regurgitation. Okay, but not in AR, MR, in mitral regurgitation. But not in a patient with a left-sided systolic heart failure. And that is not the one which will tell you a new onset symptom in a patient with a left-sided systolic heart failure. And you will not have fixed splitting in case of left-sided systolic heart failure. In left-sided systolic heart failure, what you will get is you will have reverse splitting. Right? You can have reverse splitting, but not fixed splitting. That means you can have P2 and then A2. Right? Why? Because there is left-sided systolic heart failure. So when there is a left-sided systolic heart failure, by the time left ventricle contracts and pump the blood into aorta, already right ventricle has contracted and pumped the blood into aorta. Sorry, already right ventricle has pumped the blood into pulmonary artery. So P2 has appeared. So you will have P2 and then followed by A2. It can happen. But fixed splitting will not occur. Right? Fixed splitting will not occur. Fixed splitting you will see in patients with the ASD. Fixed splitting you see in patients with the right heart failure. Right heart failure. Yes, that is what Rohit Singla. That is what I am telling you. Fixed splitting you can have this in case of ASD and as well as acute right heart failure. Acute right heart failure. Recumbent dyspnea. This is not specific for your congestive heart failure because this recumbent dyspnea can be there even in COPD also. So based on that recumbent dyspnea, I cannot tell that this patient is having the left-sided heart failure. Okay, right. And the presence of the S4 gallop. The presence of S4 gallop, like what will you have? S4 is present. That means it tells you a non-compliant left ventricle. Right? Non-compliant left ventricle. So you can have the presence of S4 in case of diastolic heart failure. Right? In diastolic heart failure, not in case of the systolic heart failure. Because S4 is present means there is non-compliant left ventricle. But yes, very good Banu Prakash. If there is S3, then I will accept. If S3 is there, then I will accept it would be the systolic heart failure, but not S4. And the other feature which tells you that it's a systolic heart failure is pulsus alternans. So in pulsus alternans, you will have alternating pulse. One contraction will be a strong contraction and the subsequent contraction can be a weak contraction because heart is very weak there, right? Heart is very weak there. Okay. So pulsus alternans is the one which will tell you in case of the left-sided systolic heart failure. Right, Rohit Singla, I will explain you fixed splitting. What is fixed splitting is? You have A2 and then you have P2. Right? Normally what should happen? During inspiration, the split will be there. Split will be present. And during expiration, the split disappears. That is what is the normal physiology. But in case of fixed splitting, the split will be present during inspiration and the split will be present during expiration. That is what is called as the fixed splitting. That is what is called as fixed splitting, right? So the answer in this question is the pulsus alternans. The answer in this question is the pulsus alternans. Okay. So this is for today. Clinical based, image based, clinical and images integrated sessions, right? So again tomorrow at the same time at 10:30, I will be there in front of you all to enlighten you with this clinical and as well as image based questions. So I hope that today's questions were very useful to you, and tomorrow I will be coming up with the questions related to your endocrinology. Right? Tomorrow I'll be coming up in front of you with questions related to your endocrinology. So you will have same image, clinical, integration of image and clinical, right? So thank you very much and see you tomorrow.